Hello, and welcome to our Behavior Health 911 event. I am Melissa Silva, the Executive Director of the Louisiana Mental Health Association. Thank you for joining us today for this important conversation. We are grateful to our community partners, especially the local governing entities that have worked with us to produce this event. LAMHA also appreciates Louisiana Department of Health, Office of Behavioral Health for sponsoring today's and 9 other events across the state. We also want to thank our panel for sharing their time, expertise, and their lived experience. Over the recent years, the Louisiana Mental Health Association has worked with our partners to identify critical issues in our local communities and our state. And in response, we offer these informative discussions on behavioral health that affect both our youth and adult populations. As our state continues to work to improve programs and services for those most in need, Louisiana Mental Health Association stands tall in our efforts to educate and advocate for those same individuals. Conversations like the one today are a small but a pivotal step towards breaking the stigma surrounding mental and behavioral health and seeking the help one may need. Before we start this discussion today, I would like to highlight a few of our spring events. Louisiana MHA will be bringing you our virtual public policy on March 2nd, 2023. This is to make it easier for those of you to attend across the state. Our 6th annual conference will be held on April 25th through 26th, 2023, and will feature live virtual sessions. Finally, our Behavioral Health Day at the Capitol will be held on May 4th, 2023. More information on all of the events will be forthcoming, but we ask that you save these dates on your calendars now. Today's panel has been pre-recorded so that we eliminate the risk of technical challenges. There will be a live Q&A after the presentations and the speakers will join us. Please put your questions in the chat. You can add them now, or you can wait till the live Q&A section. Following the event, you will receive evaluation. Please help us improve these events by completing that. Again, I want to thank you all for joining us today. I hope that you learned much from our panel of experts. Have a great day.
Hi, my name is Tanya McGee, and I'm the Executive Director for Imperial Calcasieu Human Services Authority. At MCAL-HSA, we have the honor and the privilege to work with individuals who have been diagnosed and are seeking out treatment for behavioral health disorders. And we also, in our Developmental Disabilities Division, have the privilege of serving those folks who are diagnosed with a developmental and/or an intellectual disability. We know that as an entity and an agency that we're unique in that because we serve both of those populations. And in working with community providers and partners like yourself, we have identified that there truly is a need to have people educated and trained in working with individuals who have co-occurring disorders, who have both of these disorders. So they may have a developmental disability or an intellectual disability coupled with and alongside of a behavioral health disorder. Today, we wanted to be able to provide, in conjunction with our partners with Louisiana Mental Health Association, to provide a training for you guys to start educating both sides of the fence, behavioral health and DD, on what that other disorder looks like. So today, you're going to hear from a handful of panelists who are going to provide you with a great deal of good information. And again, I really hope that this scratches the surface, because we are seeing this co-occurring population more and more in the individuals that we serve. And I think it's important for us to make sure that we have and we offer training to our providers and our staff and individuals in our community on how to appropriately work with this population. So I'm excited to have all of you guys here today. I hope that you guys are familiar with Imperial Calcasieu HSA, and if you're not, check out our website. But today is going to be a good day. The next hour and a half you're going to spend with these trainers is going to be very informative for you. And again, I hope this really scratches the surface as we move forward to building treatments and services that are geared toward helping this population. So I don't know about you, but for me, and doing this for you is the best part of my day. So I hope that after this training session, that'll be the best part of your day too. And again, moving forward as we work to build programs and services for this population. So I really wanted to welcome you guys and hope that you guys have a really great training session. Thanks, everyone.
Hi, everyone, and thank you so much for joining this important discussion. My name is Tatiana Gonzalez, and I'm the Advocacy and Education Manager for the Louisiana Mental Health Association. Today, we're going to take a look at Louisiana mental health screening data. This data was made possible by Mental Health America National. This data was recorded during July 2022 through September 2022. During this time, 7,250 screenings were conducted. This was an increase of 2,215 screeners from last quarter. Now let's dive in and take a look at what the data shows. As you can see in this map, these are the top 10 parishes that participants screened in. The first was Jefferson Parish, followed by East Baton Rouge, Orleans Parish, Other, Lafayette Parish, Ascension Parish, 7th was St. Tammany Parish, 8th is Caddo Parish, 9th was Calcasieu, and the 10th was Ouachita Parish. Please note that screeners self-identified with these parishes. Mental Health America did not determine the parishes that the screeners were in. This graph shows the top 3 mental health conditions that participants screened for. The first was severe depression, followed by ADHD likely, and the third was positive bipolar. The Louisiana Mental Health Association wanted to dive deeper and look at the demographics of our screeners. 60.57% of our screeners identified as white/non-Hispanic. Our second largest race of our screeners was Black and/or African Americans at 22.21%. On our right, you can see household income. According to our screenings, 27.59% reported having a household income of less than $20,000, and 50.09% reported having a household income of less than $40,000. We also wanted to see what gender was taking our screenings the most. As you can see here, 69.06% of our screenings were women, followed by 26.27% who were men, and 4.67% of our screenings identified as other. On our right, you can see what age group screened the highest. 61.01% of our screeners were 24 and under. This really highlights the need for mental health services in this age population. Moving on here, we wanted to ask our screeners if they had ever received any form of support or treatment for a mental health problem. Unfortunately, 54.01% of our screeners had never received any sort of treatment for their mental health problems. On our right, we also asked if they were currently receiving any treatment or support. 53.32% of our screeners said that they were not currently receiving any support for a mental health condition. Below, you can see that we asked if they had any form of health insurance. 84% of our screeners said that they did have some access to health insurance. We wanted to dive in deeper and see what special populations made up our screenings. As you can see here, students were the highest screeners at 2,322, followed by members of our LGBTQ community at 1,197, and our third highest special population were trauma survivors at 1,159. 4,678 people who took our online screening described themselves as either being a student, a member of our LGBTQ community, or a trauma survivor. We also wanted to ask if they had any form of general health condition. Oftentimes we know that mental health and physical health are overlapped. As you can see here, 337 screeners had arthritis or chronic pain. This was the most prominent health condition identified by our screeners, followed by reproductive health concerns like endometriosis at 287 screeners. Our last highest were screeners who had diabetes at 164. Lastly, I wanted to end by highlighting one of the Louisiana Mental Health Association's programs, the Fisher Project. The Fisher Project is a comprehensive suicide follow-up and recovery support service. It is a 6-month peer-to-peer case management program that is at no cost to the participant. During this time, participants are screened for suicide risk, and it's an ongoing assessment. It's aimed to create safety planning and means restriction. It also offers transitional care and a warm handoff to either the treatment or community. If you're interested in learning more about this valuable program, please contact Fisher Project at louisianamha.org or give us a call at 225-960-6800. I hope that you enjoy the rest of our presentation today. Take care.
Hi, I'm Dr. Brandy Kelly with the Office for Citizens with Developmental Disabilities. I have had the opportunity to provide treatment and services for individuals with IDD and behavioral health needs for over 2 decades, and I'm very happy to have an opportunity to share some information with you as IDD professionals and providers on how you can support individuals with IDD and behavioral health needs, recognize when you may need to get someone to a professional for some additional assistance, and communicate with those professionals to best meet these individuals' needs. Despite the fact that for some time in the past, individuals with IDD were thought to not be able to experience behavioral health conditions, it isn't known now that they have a greater risk of developing behavioral health conditions compared to their peers without IDD. It is commonly accepted that over 1/3 of individuals with IDD will experience behavioral health conditions. And we know that depression and anxiety rates have increased since COVID. Additionally, individuals with IDD are more likely to experience trauma. In fact, it is believed that 80 to 90% of individuals with IDD have experienced at least one trauma event. Many individuals experience multiple trauma events, and over half of these individuals never receive treatment. You can see, based on some of the information I've shared here from Louisiana, that our data is consistent with these rates. In the National Core Indicators Survey, which is a survey done by the National State Director of this Developmental Disability Services Group, 25 to 35% of adults have a formal behavioral health condition diagnosis. 11% of youth do, but 50 to 68% of adults note they struggle with self-injurious or destructive behavior, and 43% of youth do. When we look at adverse childhood events in Louisiana, 90% of the individuals that we've looked at experience adverse child events, with more than half of them experiencing multiple events. So this is consistent with the data that we have nationally. And it also is clear that this is more traumatic events experienced by individuals with IDD than what you see in individuals without IDD. So from this information, we should know that individuals with IDD should be expected to present with behavioral health conditions at the same rate or more than individuals without IDD, and that we should have a greater expectation that they will have experienced some trauma, even if we don't know about said trauma. As an IDD provider or professional, it may make sense to look at how we support these individuals in sort of a hierarchical fashion. And one of the things that we can do in the developmental disability system to help individuals be protected against developing behavioral health symptoms is to remember that everyone supported needs us to focus on wellness, trauma-informed practices, and the person-centered practices we often talk about in the developmental disability system. And these are the foundation of support. It is important that we are doing this for everyone that we provide any support to. Next, we also want to be sure that we are really focusing on helping someone build skills and independence. Because when someone can be more independent, they are able to access the things that matter to them, including the things that are important for their wellness, and also to protect themselves and to have the right coping strategies to protect against trauma. When someone has problems, one of the first things you want to do is go back and check these things that as a DD provider or professional, you can address and fix, because sometimes something happens in someone's life and we just need to go in and fix it or address it. And when someone has some communication and cognitive challenges associated with their disability condition, they may be telling us when something is not right by behaving in a certain way, or they may show us some emotions that clearly indicate that something is not right. So we want to go double check these things first, because it may or may not be that the person actually is experiencing behavioral health symptoms that need to get to a professional for assessment and treatment. If the problem continues, despite your checking and addressing these gaps, that is when you will need to know that you need to get someone to the professional. That professional then will look at whether or not there's any treatment or therapy that is needed. And then for some subgroup of those individuals, the therapist or professional may give you some written instructions that staff will need to follow to best support this person. So let's talk a little bit about conducting that person-centered and wellness check. You want to make sure that the person's non-negotiables are present. All of us have those non-negotiables. You've likely been in trainings that we've done from OCDD before where we talk about non-negotiables. These are important. And if anything is missing, we need to be sure that we correct that and make sure that the person has unimpeded access to that. Similarly, we need to think about wellness. Wellness is a part of our non-negotiables. In fact, the things we need to be well in life across all of our life areas are some of the most important non-negotiables, but they're not always the things that people think about. So you need to think about someone's social wellness, emotional wellness, physical wellness, intellectual wellness, occupational wellness, and spiritual wellness. And are we really paying attention to what matters most to them in all of those areas and making sure that they have access to those things and any support needed in that regard? You also want to check and make sure all of the important relationships and connections are still present in someone's life, that nothing has happened to make that harder to access or to get in the way of any routine calls, visits, or activities that matter to the person. Check and make sure that nothing is changing during the day. Are work and school going okay? Are they matching what matters to the person? Does the person still have access to the things they enjoy each day? Do they have choice and control in their day in a way that matters to them and is being respected? Have there been any staff changes? And has that resulted in any mismatches between what the person really wants to do and how they want to spend their time versus what the staff's preferences might be? That won't make the staff a bad staff or a bad person. It just means it's not a good match and we may want to make a change. Make sure all supports for communication are present so that the person is able to share with people what matters and what they want in any given day. And be sure to check that no major life changes have happened. Individuals with disabilities are going to have normal emotional reactions to life changes just like we are. And it's okay at times to not be okay, as long as it's not something that is longer lasting than we would expect or something that is dangerous or concerning. So if someone has lost someone in their life, if they've had a major life transition or change, you want to allow someone the space to feel typical emotional responses, just like any of us would. So when you look at this, then you want to take action if that is appropriate, if you find any concerns or gaps. Once you've done that and you're looking at problems persisting, you want to make sure the person gets to the right professional. And we do know that when someone is not feeling well, they also may behave in a certain way or have certain emotional reactions when they're not able to communicate that to us in other ways. So you want to be sure that you look for any possible pain or discomfort, right? Attend to any verbal complaints of pain or discomfort. Know how the person communicates and pay attention to cues of possible pain or discomfort. And notice if they're moaning, groaning, or crying in conjunction with other behavioral reactions. It can be easy to focus on the outward behavioral manifestation, if that is someone hurting themselves or others or being destructive. But if the person is telling us they're not feeling well, if they're communicating in any way pain or discomfort, or if they're moaning, groaning, or crying, then we should err on the side of first assuming they don't feel well and getting that taken care of. This is particularly important if there is a sudden change in someone's behavioral presentations or a brand new behavior that has never been present before, or a behavioral issue for someone who's never had any behavioral concerns before happens. So you want to check a few things too. You want to be sure that there's no irritants that are happening in the person's life that may be causing discomfort that you can fix. Check to see if there are any changes in soap or detergent. Check and make sure that no recent med changes have happened. And if they have, you may want to go to whichever physician actually made that change and say, hey, something is different since we made this medication change. If the person uses any equipment to move around, you want to also be sure you think about when was that checked? Could there be some discomfort associated with that? And then, of course, if there are any signs of pain or any medical symptoms that accompany any behavioral changes, you want to get them to the medical doctor or nurse practitioner who they see, so that action can be taken to address the medical issues. And for some individuals, when this happens, that behavioral manifestation you were seeing will actually be treated because the underlying medical issue is treated and it will go away. Some common things you may want to think about is when behavioral issues are surrounding mealtime or it involves putting hands in their mouth, you may want to think about whether or not there's any stomach or digestive related issues. When someone appears to be inappropriately touching themselves, especially when it's not something that just happens ongoingly, it sort of comes and goes, or it happens kind of cyclically and seems to be linked to when their menstrual cycle is changing. You want to make sure you check out any gynecological problems. If someone has any heart or blood pressure issues, you want to be sure that things are not changing when there are also significant changes in blood pressure. When someone has diabetes, you want to be sure that you're not seeing significant changes when blood sugar levels change or related to dietary issues, because these can all help you figure out that you really need to get someone to the medical doctor. You can also look for if you see any signs of possible mental health conditions along with what might be those outward behavioral manifestations. So you might want to think about whether or not the person is showing any signs of anxiety or trauma. Are they worrying when nothing new seems to have happened? Do you see any clear signs of fear or panic? Is the person avoiding certain people or things? Are they sweating, pacing, shaking, but there's no real medical explanation? Has their sleep pattern changed? Do they maybe appear to wake up afraid or startled? Are they checking things or having a pattern of repetitive behavior that you know isn't associated with their disability condition like autism? When you think about possible signs of depression, is the person crying for no clear reason? Has their sleep or eating patterns changed? Do they no longer enjoy or want to do the things they previously enjoyed? Are they withdrawing from social interaction, especially when it is a change from what they previously might have done? When thinking about mania or manic behavior, mood can change without clear reason. Maybe switches back and forth, crying, laughing, crying, irritability. Mood seems to not match what's going on. Risky behavior happens, but it happens kind of in cycles. It comes and goes. Person is making poorer decisions than is typical for them. If you think about psychosis related behavior or paranoia, does the person say or act in ways that might make you think that they're being paranoid? And it's different. They think people are out to get them or watching them. They talk to others who are not there. They react in ways that seem as though they are hearing something that is not there. They hit or scratch themselves as if trying to get something off their body that is clearly not there. If you see any of these things, in addition to behavioral manifestations, then you will probably want to get someone to a behavioral health professional, and you need to be sure to share these symptoms and not just what those outward behavioral manifestations are, so that the behavioral health condition can understand what might be going on and have the full picture. You can also do some things in supporting someone while you may be waiting to get in to see a professional. So if you think you see some signs of anxiety or trauma, make sure you know who the person thinks is safe and likes to talk to when they're distressed and that they have access to that person. Don't insist on any demands or quote compliance with tasks unless you have some clear guidance or it's a major health and safety issue if someone doesn't do something. Assure access to calming and soothing activities. And don't assume that this just involves taking deep breaths because that can actually make some people panic more. If you think someone may be depressed, lower your daily expectations for activities, focus on the ones that are most enjoyable, gently encourage good sleep and eating habits. Do not force that, but just gently encourage it and help them practice daily gratitude, even if it's mini gratitude, looking for just small things that they might be thankful for. If you think someone might be showing some signs of mania, you want to get them to a clinician quickly. And while you're waiting, you want to alter expectations for daily activities based on what they can focus on and also considering that they may want to move around more. Again, gently encourage good sleep and eating habits and make sure staff alter their expectations and patterns, especially for some nighttime expectations. If you think someone may be engaging in behavior or symptoms of psychosis, paranoia, or delusions, do not engage in discussion or debate or try to correct those. Provide access to and encourage engaging in enjoyable and calming activities. Know who they seem to feel comfortable with and make sure they have access to that person. And then, of course, make sure you get them to a clinician. And when they have a clinician, you want to make sure you always know what signs and symptoms to report and get them back to that clinician. You might at times need help. So you need to know that obviously if there's an emergent situation, you want to get to emergent services, you may need to call 911. There is a new suicide and crisis line, which is 988, that can be called when someone is having a behavioral health crisis. So make sure that you remember that, you share that with staff, because they can maybe help get an individual to some more crisis or critical support in a time of need. You want to know who the person's health plan is. Anyone who receives Medicaid has a health plan for behavioral health services, and you want to know how to get that person to their health plan contact for assistance. Know if there's someone within your agency that you need to contact when certain symptoms happen, and what your policies are and when to ask for help and to whom. And always be aware if someone already has a professional involved and make sure that you know from their perspective what you should look for and when they want you to call them and what type of information they want you to share. So here is a summary of some of what we talked about. We will make this summary available. You can see things you can do yourself is when there are known life changes. The behavioral presentation maybe is only happening in one setting. So maybe that is a sign it's not a behavioral health condition. It's low level of danger. Person already has a known medical condition and they're having symptoms. You know what the medical treatment approach is. You want to get to a medical doctor when something is very new or sudden. You know that the person has some possible genetic or family history issues and or there are clear signs and symptoms of illness. You want to get to the prescriber if the person receives medication for mental health conditions, you think something may be going on, or there are some other odd behavior that might also tell you that there's some side effects, or you think the person may need to be taken to the hospital or undergo a PEC or physician's emergency certificate. You want to get to a behavioral health professional if the behavior is a little bit more dangerous, so you can't really kind of try to figure things out yourself first. Your efforts to troubleshoot simple solutions don't work. You've ruled out medical issues or it's very clear that that's not likely. Maybe they have a known mental health condition they've received treatment for before, and you don't have a reason to think you need to get to the prescriber, or they've previously engaged with the professional and the problem is reemerging. You want to call 988 if the person is suicidal or needs help urgently for symptoms of a worsening behavioral health condition. And you want to seek emergency services either through 911 or the emergency room if the person is in imminent danger to themselves or to others, there's a major change in awareness or alertness, or there is a medical emergency. We do have the ability to also provide some additional assistance. So at the link here, which we will make available to all of you who participate in the panel, we have some wellness tools and tips that can help you and are going to reference some of the things I've covered in the presentation today. The OCDD Resource Center is also available. The Resource Center has clinicians throughout the state who can assist. We have clinicians across behavioral health, allied health, and nursing, so we can assist across multiple disciplines. Our primary mission is to build community capacity to support individuals with IDD and other complex needs. So if the professional that is providing treatment wants consultation, you can reach out to the Resource Center. If you aren't sure if you need help or from whom you need it, you can reach out to us. If you or your agency thinks some additional training is needed, you can reach out, or if you need help interacting with a professional. And we can be reached at resource.center@la.gov. You can also go to the OCDD Resource Center page on the web for more information. Thank you for the opportunity to present to you today, and I look forward to our panel discussion. Thank you.
My name is Ashley McReynolds. I am a parent of a 16-year-old that has a diagnosis of an intellectual disability and also has a co-occurring behavioral health condition. I am a program director at the ARC of Louisiana, and one of my contracts is with the Southwest ADA Center located in Houston, where my focus is on healthcare disparities for the population, specifically with individuals with disabilities, including those with intellectual developmental disabilities and co-occurring behavioral health conditions. My goal with this contract is to identify disparities and barriers that this population faces, and then work with professionals, including physicians, nurses, social workers, psychologists, psychiatrists, individuals that would be treating this population, to bring awareness to the barriers and the disparities that this population faces, provide them with pretty common sense tips in communication techniques and simple accommodations and modifications that they can make to their practice to ensure that these individuals receive equal access and adequate services to improve their lives. So I spoke briefly about being a parent. My son Cooper is 16. He has a rare syndrome called Prader-Willi syndrome, and also suffers from a couple of different behavioral health conditions. He suffers pretty significantly from anxiety, and also has a diagnosis of bipolar. He has struggled these last probably 3 years pretty significantly in finding a provider who was willing and able to treat him. We've struggled with medications, just in general finding services, especially when we reach crisis level, and we're unable to secure a bed for him when he was really in crisis. So it's really become a priority for me for this population. And so I'm thankful for the opportunity today to get to share some of the work that I'm doing with you. So let's just first start with the mental health of people with disabilities. There's all kinds of studies out there that show that adults with disabilities, individuals, youth as well, experience mental distress far more frequently than those that do not have a disability. So you can see here in 2018, 32.9% of adults that have a disability reported frequent mental distress. And that is defined as 14 or more reported mentally unhealthy days in the past 30 days. So these individuals are spending about half a month at a time in mental distress. We all know that, with mental distress comes with extremely poor health behaviors. You utilize health services far more frequently, and most of those are more expensive because they're in emergency department settings. This affects, of course, chronic conditions and acute conditions, and really limits individuals in their activities of daily life. So prior to 1960, it was believed that individuals that had an intellectual or developmental disability were just not capable of having a co-occurring mental health condition. And they also believed that these individuals would not benefit from the same type of services that people without disabilities, when they went to receive treatment for behavioral health conditions, could actually benefit from. Some of the most commonly recognized conditions co-occurring are depression, anxiety, bipolar mania, and then psychosis and schizophrenia. While it is very much recognized that there's a very high prevalence of behavioral health conditions among individuals with IDD, there is very little known about the best approaches for the needs of these individuals and the challenges that these individuals and families face. So it is known that people with intellectual developmental disabilities are more likely to be impulsive. They're going to have several co-occurring medical problems, not just IDD and behavioral health. They're going to have several medical complexities. They are going to demonstrate challenges in any type of like self-monitoring and self-regulation. They're also going to have difficulty with problem solving. They are going to have limited self-calming skills, and then also have limited language skills, which can make your everyday treatment for behavioral health conditions a little bit more challenging. So on top of just the behavioral health IDD co-occurring, there are also other risks associated with this population. They are at a much higher risk of having physical health conditions, which then can also contribute to an increase in the risk of other mental health conditions. They have for a very long time had their symptoms of a behavioral health condition being misattributed to their intellectual or developmental disability, rather than being recognized as a part of the manifestation of the actual behavioral health condition. This population also experiences much higher rates of physical and sexual abuse, which can then also magnify their vulnerability when it comes to behavioral health. So here's where we are today. Because of all of this uncertainty, unfortunately, it has led to the dependence of very outdated and honestly, just really bad approaches to mental health care for this population. It has led to the use of restraint and seclusion of these individuals, the overuse of psychotropic medications, which can actually cause this population to further struggle with anxiety and some of the other behaviors that come along with their specific mental health condition. It puts a very significant strain on any family support or natural support that these individuals receive, because they're left with very little services available in the community that are able to provide the proper supports to keep these individuals in their homes and in their communities where they want to be. So I have some Louisiana facts. According to our last census, our population is about 4.7 million. And almost 4% of that live with serious mental health conditions, such as schizophrenia, bipolar, and major depression. So nearly 1 in every 5 adults. Compared to the rest of the US, we are higher. So we have 21.2% of adults in Louisiana with a mental illness compared to 19.9. And then when you look at our Medicaid population, there were in 2019 about 40,000 hospitalizations due to a serious mental illness, which is quite significant. If you don't know, there was a Department of Justice investigation that was done, and they found that the state was improperly relying on nursing facilities to serve individuals with a serious mental illness or behavioral health condition. instead of providing these services in an integrated setting that was most appropriate to meet their needs. So this led to the Department of Health entering into an agreement with the DOJ that was very specifically detailed and outlined all of the expectations regarding these activities related to those that were residing in nursing facilities, and also just our overall behavioral health service system. And it required them to develop a crisis system of care, which we did not have prior to this Department of Justice finding. When you look at just some more facts, we rank 45th in the US for access to mental health care. So that's in general, that's not specific to individuals with intellectual or developmental disabilities. That's the general population. When it comes to individuals with an intellectual developmental disability, that number is actually probably worse, probably might be 48th or 49th. There's a big reluctance for clinicians to see individuals with an intellectual or developmental disability. But we'll talk about ways that we can sort of break down the stigma around physicians not wanting to serve this population. But when you look at some further statistics, 61.8% of those that report having a serious mental illness, they report receiving absolutely zero mental health treatment in the state. So OCDD, or the Office for Citizens with Developmental Disabilities, does a survey every year. It goes out and it's referred to as the National Core Indicators. This data runs behind, so it's not that I don't have more up-to-date data, just the data coming in is delayed in reporting. So the most current data that I have is from 2018, 2019. And so these are individuals that have a diagnosis of an intellectual developmental disability. And in the adult survey, we had 25% of adults reporting a psychiatric disorder. 50% reported self-injurious behaviors or disruptive behavior. When we looked at the results for the adult family or the guardians who filled out the survey, 35% of them reported having a psychiatric disorder or diagnosis. 68% reported supports for self-injurious and destructive behaviors. So they had a need for these types of supports, but were not able to find them. And for the child family, 11% reported having a psychiatric diagnosis, and then 43% reported the need for supports for the more serious behaviors. So overall, these are more statistics that were done in a different survey from 2017-18. And I don't need to go through all of the numbers, but you can just see overall the statistics and the prevalence of having a significant mental health or behavioral health challenge in individuals with intellectual disabilities is very prevalent. And unfortunately, the supports and services for these individuals are not available in the community, and they are also not available when a person enters a crisis situation. So how did we get to where we are? Our previous administration started about 15 years ago when budget cuts were made, and the state closed the only 2 inpatient facilities that were available for inpatient treatment for these individuals. They were staffed with physicians, nurses, psychologists, other allied health staff that had the knowledge and expertise to provide treatment to these individuals. We had a stabilization unit, or an SU, and we also had a developmental neuropsychiatric unit, or the DNP. What's really needed now is, again, something specifically to treat this population, but we also need services across our entire continuum. We have to have better access to community-based treatment. Right now, it is very limited. And families report what's available is just not meeting the current needs of their loved ones. So some of the of needed services are therapeutic respite. There are, I think, about 7 center-based respite facilities across the state. Unfortunately, these facilities are very hesitant in serving individuals that have sort of violent or destructive behaviors. So the one thing that is available for these families, these facilities are just not leaving individuals and families to struggle alone. As a family member, as a parent of a child that has very significant behaviors, I can tell you that we definitely struggle alone. We tend to hibernate in our homes out of fear of bringing them in public and having behaviors, people not understanding the behaviors, police and law enforcement not understanding the behaviors, and it really just becomes extremely isolating for families. What has also occurred is the state is actually paying to send individuals out of state. I know families that have gone to Kennedy Krieger. I know some other families that have traveled over to Texas Children to receive inpatient care and treatment. They are also admitting individuals into Pinecrest up in Alexandria. And that alone costs about, well, it's over $200,000 a year now, because we just don't have the proper supports and services for these individuals. We also have a very significant shortage in psychologists and psychiatrists, that just in general. And we also lack those that have the proper knowledge and expertise to serve this population. Okay, so when I've talked with parents, individuals with disabilities, the key issues that they always are bringing to the forefront is that our mental health professionals lack key knowledge about individuals with intellectual and developmental disabilities. The disability and the mental health care systems are extremely complex. They are not very flexible, and they often do not interact or speak to one another, leaving families having to navigate multiple systems to find, a continuum of care for their loved ones. When it comes to an individual having an intellectual developmental disability, these individuals report that they really struggle communicating effectively with their physicians. And when they feel like they're communicating effectively, they often report that they feel like the clinician or the physician does not, I guess, understand them in a way that they feel like they're actually being heard. So, and again, individuals that have a dual diagnosis, parents that have a young child or an adult that have a dual diagnosis, and then the other family members in that family unit always report feeling completely isolated, like they're alone on an island. And it's a direct result of the lack of understanding, the continued discrimination and stigma related to this population. So what are some of those barriers to the service system? I broke down the 2 service systems that this population receives services from. You have OBH, or the Office of Behavioral Health, and then the OCDD system, Office for Citizens with Developmental Disabilities. These systems have very little or actually no collaboration at all. So when you look at how these services and supports are different between the 2, within OBH, the services and the supports are often short-term based on acute onset of symptoms. Compared to the DD system, these services and supports are a continuum across the lifespan. ODH really only focuses on any type of psychiatric need. And the DD system emphasis is on direct support, so specific to the needs of that individual, related to activities of daily life. The ODH model, again, recovery model, medication, management and treatment. The DD system is very patient-centered and does offer some behavioral support, but not to the level that is done in the ODH system. Overall, between both systems, there is a lack of funding for services. I will say in this current administration, there has been an emphasis on the funding for services for people with disabilities and those that have an IDD. We are in a much better place than we were 8-10 years ago. I mean, significantly better place. We also find that even when families find a provider that is willing to serve this population, it is very difficult to find when that individual's only insurance is through Medicaid. There are a lot of administrative and just bureaucratic red tape that makes it very difficult for the family and the individual to access service without a lot of hurdles that they have to get through before they get into the door to receive the service. There is very much so inconsistent crisis procedures, and this causes a lot of confusion for individuals and their families. They will be notified about a procedure or about a support or a service available. But then when they actually get and explain, this is what my child needs, this is, their current issues, the provider may actually say, you know what, we just can't serve them. There is a very significant direct care worker crisis, which has put another strain on the system and leaving individuals with intellectual developmental disabilities from receiving consistent support and care, which can also then have a negative impact on their behavioral health challenges. And then there's still a lack of accessible and public transportation. This has been an issue, especially in our rural areas. Finding, whether it's medical transportation or, an Uber or a taxi or a Lyft, there aren't accessible transportation providers. And if there are, sometimes you have to try and plan for these trips months in advance. So just being able to access a provider is extremely difficult, especially in our rural parishes. So healthcare access, it is one of the biggest barriers for this population. The stats are staggering when you look at 1 in 3 adults with disabilities between the ages of 18 and 44 do not have like a general practitioner or an internist. They don't have that, yearly check-in. They don't have a provider like that. 1 in 3 adults report having unmet healthcare needs, strictly related to cost. And it can also be due to that provider not taking Medicaid patients, because that might be their only form of insurance, which has led to 1 in 4 adults not having a routine checkup in the past year. And those were individuals who were between the ages of 45 and 64. So you've heard me talk about Medicaid. Unfortunately, it's not just a Louisiana problem, but here in Louisiana, it is, I feel, almost worse than the rest of the United States. Most mental health providers do not accept Medicaid. And that is due to the lower reimbursement payment rates. If they do accept Medicaid, you will often find that they are currently not accepting new Medicaid patients. So just when you think you found a provider that takes Medicaid, you'll call and try and schedule an appointment, and parents will hear, I'm sorry, but they're not taking new patients right now. And they'll sit on a waiting list. This is one causing a strain in emergency departments, because individuals and families are turning to emergency rooms for care, or when they reach a crisis situation because they haven't been able to get into their psychologist or psychiatrist. This population just doesn't participate in Medicaid and Medicare the way that other physicians do. A lot of them are cash only. They don't accept any insurance at all. So this is, just another barrier in access. Individuals with disabilities, adults, most of them live on fixed incomes and cannot afford to pay out of pocket to receive behavioral health care services. And then we also see psychiatrists being selective about, whom they're going to treat. So you may find if you're, somebody that has a very mild intellectual disability, they may treat those individuals compared to somebody that might have a more significant cognitive impairment. So there's a lot of issues when it comes to providers, Medicaid, the cost to receive these services. But before I go, I do want to share a little bit about the advocacy piece to this, and the importance of individuals and their family members, caregivers, to bring these issues to light. And without the personal stories, efforts that are currently going on to bring awareness to these issues that this population faces, the needed supports, the lack of supports that are currently available, would not be taking place if it wasn't for individuals and families sharing their stories. So I think it's, as a parent, I share what's happening in my life with my elected officials. I keep my representative, my senator, up to date of the issues that we face. It's crucial that they understand what's happening, because if it's not happening directly to them, to be honest, they just don't have time to think about it or worry about it. So I do want to express the need for you and for others to share the struggles that you're facing every day, because if people don't know, they don't know that it's an issue, and things will never get changed. It's difficult to share your story because it's hard to talk about all of the bad and the doom and the gloom that comes along sometimes with behavioral health conditions. It's hard. As a parent, I don't like to talk about the struggles that Cooper faces every day, and how it has impacted my ability to work, my ability to go out and enjoy the community like so many other people do, family holidays, field trips. I mean, going to the grocery store, just simple things that people who aren't living it don't think about. And it takes stories like mine and like yours to, one, bring these issues to light, and then two, drive the change that's needed to ensure that these individuals have the community supports, the more inpatient treatment if it's needed, because right now we don't have any. But I will say there is a lot of work going on at the department between OBH and OCDD on what's needed, what does this population need? And it's also not a Louisiana issue. This is an issue that every state is facing. And there's a lot of conversation around it. So if you haven't gotten involved yet, get involved now. If you want to reach out to me, you can. Again, this is all of my contact information. And I'm hopeful that we will have some efforts come forward in the next legislative session. It either begins in March or April, I'm not sure. But I'm hopeful that we can start bringing some changes and policies, maybe some new services that we haven't had before, forward for the legislature to consider and hopefully fund. So again, thank you so much for inviting me to participate in this today. And I'll be around for the live Q&A to answer any questions later.
All right. Hi, everybody, and thank you so much for joining us today for this important panel discussion with Ashley and Dr. Kelly. Again, we want to thank Imperial Calcasieu Human Services Authority for partnering with us on this discussion. The Executive Director, Tanya, saw a real need in getting awareness for this specific population when treating people with behavioral health conditions, and just like we learned through these panelists, how little services are available and the hoops and barriers that family members have to jump through to get their family members in those services, if they even exist at all. So thank you again, Ashley and Dr. Kelly. We did have a question come in through the chat, and or the Q&A box. Someone said, is there any type of information that can be shared with us regarding the adverse effects of using restraint and seclusion within developmental disabilities or intellectual disability populations?
You want me to go first, Brandy?
Either way.
Okay. I know there's stuff sort of everywhere about the use of restraint and seclusion, and the negative effects, of it. I don't know if Louisiana has anything specifically. And Brandy might be able to answer from the department level, if they have some information that they can share. But really with, restraint and seclusion, the studies and the facts are clear about, the damage that can be caused when it's used and not used properly, and that it's overused in situations when an individual isn't necessarily a danger to themselves, or somebody else. The behaviors might just be too much and have gone on too long, and people are forced into being restrained and secluded when they shouldn't be. And then also a lot of times with law enforcement officers, the use of restraint and seclusion can lead to unfortunate death of individuals and an injury. So I think if you're looking for something specific to Louisiana, Brandy might be able to answer. But if you're just looking for general information, it's pretty well documented that restraint and seclusion should really just be a last resort.
Yeah, and it kind of depends on what the person asking the question meant by information we can share. I mean, we can certainly share right now what we know. If someone is looking for something in particular, it will probably help to know really what they're trying, like what's sort of the intended use and what do you want to know. We don't collect a ton of data on that in Louisiana because we don't use it. So I can't say that there aren't some psychiatric hospitals that may use things, but in the DD system, seclusion is prohibited. So you cannot use it at all. in the waiver services, so in the community, most forms of restraint cannot be used. So we obviously acknowledge, I mean, if someone is, about to walk into the street, you want to stop them. If someone, so we don't have a total hands-off policy, but there's there most forms of mechanical restraint, for example, you can't apply that in a home at all. And within the intermediate care facilities, each facility has its own policy. I can tell you at our facilities, there is a very, very high level of scrutiny and level of authorization that has to be obtained before that can be used. And then there's a lot of debriefing afterwards. Keep in mind that we shared the significant rates of trauma for people with disabilities. And so any form of putting your hands on someone can really significantly re-traumatize someone. It is not, restraint is not used any longer anywhere as an actual form of treatment. It is used as a crisis method if it is used anywhere. And what you see across the country, really across both psychiatric settings and disability settings, is a move towards elimination of those types of procedures. So, so we know good doesn't happen. We know that it means something went wrong, right? We some opportunities to intervene or do something different might have been missed, or someone is in a legit emergency situation that couldn't have been anticipated because we shouldn't be using it otherwise. I can tell you that there has been an individual who was receiving the waiver. So to Ashley's point about interfacing with law enforcement, there was an individual who was receiving waiver services, who police were called while the individual and their family were out in the community. The individual was definitely having a behavioral episode, but he did pass away. And there was a lot of concern and speculation about the type of sort of, the type of procedures they used in attempting to sort of restrain him and get him to calm down. So, again, I don't know if people are looking for something particular besides us just saying we should really not do this most of the time, if ever, and good stuff doesn't happen when it happens.
Right. And that's a tragic story that you just shared. The person who asked the question, and I know I'm not going to pronounce this right, so my apologies ahead of time, but they put contraindication when it comes.
So, there can't, so if you know that someone has a trauma history, and again, remember 80 to 90% of individuals with IDD are going to have a trauma history, that is often seen as a contraindication. There are also some significant medical issues that would be contraindications for use of restraint, but that really, it's not going on a list. You should always, you should always be checking with someone's actual primary care physician about any type of physical intervention or engagement that should be avoided. So again, in our facilities, we don't do any sort of restraint without an actual sign off by the physician. So, that.
Okay. And then I see somebody else in the chat put, who monitors and approves the plans for this use of these inside. I'm gonna try to reword this. Who monitors and improves the plans for the use of these inside of private ICFs to ensure these individual private policies meet best practice?
So every ICF has to be surveyed by health standards, and the use of those types of procedures are part of there's regulatory requirements. So they are looking at that information anytime they are surveying those facilities. So in terms of state oversight, that's the oversight arm. Within the facility, there should be oversight by administration and any treating clinician that is engaged with those individuals.
Okay. And Ashley, could you elaborate a little bit more on what the ARC does and maybe how disability professionals can refer their clients or family members to the programs that y'all offer?
Sure. So the ARC of Louisiana is really the advocacy branch here in Louisiana. We have affiliated local chapters that are the ones that actually provide services to individuals, both in waiver services and those that receive services in community homes. So we work with those chapters, we work with families, individuals, to bring to light issues that they're facing, in the communities, whether it's related to services, employment, I mean, anything that that you can think of. I also am over a grant that we receive funding through the Southwest ADA Center located in Houston. And for this grant cycle, we worked really heavily to try and build a piece in there specific for dual diagnosis and raising awareness in Louisiana about the healthcare disparities that these individuals and these families face, the barriers that we constantly are trying to break down to receive, services and treatment. And we're working really collaboratively with the department, Dr. Brandy Kelly and her team. We've put together a provider guide that we'll be releasing at the beginning of the year that will be available to everybody to utilize. We're going to be working on a family and individual caregiver guide as well. And we've really focused the last couple of months. We passed an HCR during the session that brought together a group of stakeholders to really dive into the needs of this population and look at what we currently have in our system, and then sort of what's needed and how do we go about getting that. So funding, is it space? Is it clinicians, providers, all of that. So I'm always looking for families to join us when we meet with our legislators to share their stories, to attend our trainings. We provide, in-person and Zoom trainings. So if you are interested in, in any of that, or you want to send a family my way, please do. My contact information I know is in the slides, and I'm sure, they'll get a copy of it, but I would love to, and to partner with providers and hear from providers, because I hear mainly from families about what their barriers are. And then when I work with clinicians, it's, sort of within the systems and not so much on the private side. So I would really like to hear from providers, like specifically what are your barriers to treating this population? What can we do? What do you need? And how can we advocate for that? Whether it's legislation or just policy changes, like what can we do to help you to better serve this population?
Great. And yes, I'll be sharing the recording of this to our Louisiana Mental Health Association website, where you'll see Ashley's contact, but I'll also share it with the survey that we'll send out on Monday after this meeting ends. And we do have a couple more questions before we wrap up, but what tools and tips are most important for providers and families to know about when it comes to treating this population?
So, well, I would say that the providers and families are not the ones who necessarily need to be worried about how to treat it. They need to know where to go, and they need to know what to do to not make a situation worse, to better recognize early signs of issues, to get to the right professional. And so one of the reasons that I did share the link to some tools, and I went through that sort of hierarchical approach, is that that is what those tools are specifically designed for. And the most significant tools are the foundational tools. So it's understanding wellness. So we have a wellness guide on that site that is very simple. It's a page. Now, obviously, if you type into it or write into it, it can get a little longer, but it shouldn't really be more than a back and front or whatever. But just a way to capture what are the things that really are important for that person's wellness, and which of them do they need support to access, as opposed to what can they do independently, and really sort of reshaping a lot of times for folks with disabilities historically, because of some of the types of treatment approaches that have been used, anything can be done to an extreme. And so many individuals, it's almost like there's this belief or this pattern of, everything good in their life gets used as a reinforcer. And, you know, they have to earn it, you know, and I always say to folks, like, I don't know about you, but like, I wasn't perfect today. And I still got to call my mom if I wanted to, and I still got to go sit outside, and so, you know, there's a place for reinforcement of certain skill building when you're doing that, and that's fine. And there are also times when something is so dangerous, right? It's really a safety issue. You're not going to go certain places. But the things that are important for our wellness, they actually need to be accessed in an unimpeded way. You know, that's what sometimes makes the difference between whether or not something is sort of better or worse. It doesn't mean someone won't have a behavioral health condition, but it sort of builds some protective factors in there. And so really understanding what those things are. We also have a guide to what we have called, we are now calling within the resource center, universal behavioral supports. You don't need a plan, you don't need a clinician. This is just what you should do for every person that you're supporting if it is something they need help with, or don't get in the way if they don't need help, right? And so a lot of those things are there. And then we have other tools that you can use depending on what happens with the person. So all the tips that I went over of signs and symptoms that might make you think someone needs to get to the medical doctor, signs and symptoms that might make you think someone's anxious or depressed or whatever. So it's all right there. It can be used as it's needed. But again, you got to start with the foundation, and the foundation is the wellness, the trauma-informed stuff, and sort of the universal behavioral supports that we do for everybody.
Great. And we will be sharing those links, like I said, on Monday for everyone to get a hold of. The final question is, what can DD providers do to better coordinate with behavioral health professionals / managed care organizations?
So we also have some tools in that link for that. I will say the biggest mistake I see is what we communicate. So we often go to doctors and other professionals, and there is an over focus on the person's disability condition. And I will say that when you walk in a door of a behavioral health professional, for example, if you are wanting someone to understand why you are there to see them, you have to give them a flavor for why do you think something emotionally and behaviorally is going on, not you know, leading a lot with the disability needs and the disability condition, because sometimes it sort of sends the message that you're really struggling with something related to the disability, and then that's not really what they need to do. So that's number one. Number two, don't ask for a behavior plan. I mean, you may get one, you may need one. Some people need applied behavior analysis. But if you walk into the door of you know, somebody who does cognitive behavior therapy, or you know, you're trying to engage with a multi-systemic therapy team, that may be the type of therapeutic approach the person needs. They don't write behavior plans. So you're going to automatically get them to say to you, we don't do this, so you need to go someplace else. And that may actually delay treatment for the person, and they get them to the wrong professional. They may not need, not everyone is going to respond to ABA. Not everyone needs ABA. Individuals with disabilities need the full spectrum, you know, access to the full spectrum of services, just like any of us would. So don't ask for what you need. Tell them what you're there for. Tell them what you need help with. We have a clinician visit form for communication that they can access on that link that can help with doing that, whether it's a new visit or it's a return visit. There's also some questions that that are designed for the clinician to complete. If the clinician's like, I don't have time to fill out a form, well, you can just use it to like be the questions you ask if you're there with somebody and you're trying to get information. So those are my quick tips.
Thank you for sharing. Ashley, do you have anything to add to that?
No, I think just to emphasize what Dr. Kelly said about, you know, I don't want to say let go of the disability, but in order, you know, to get the best possible picture painted, is to really step back from the disability and, you know, and try, although it's hard to do, it's very hard to do, is, you know, to sort of leave that on the back burner. And again, what Dr. Kelly said about talking about why you're there and not what you need is really crucial, both for professionals and for family members to really understand, to have the best possibility of having a good outcome is, talk about why you're there, not what you need. And then, if, to try to leave the disability, I guess on the back burner, would be my advice for families and individuals.
Thank you. I want to thank again, Dr. Kelly and Ashley for being really pivotal panelists in helping us put together this presentation. It was quite difficult to find a third panelist, and I think that truly does show the lack in just this information being made public or even awareness for it. So again, Ashley and Dr. Kelly were so pivotal in making this presentation happen, and we're truly grateful for them. If y'all have any further questions for our panelists today, you can email me and I will direct them to Dr. Kelly and Ashley. We will be sending out a survey at the end of our event. Actually, I'll be sending it out on Monday, and the recording of the event will also be posted on our Louisiana Mental Health Association website. We also want to thank Imperial Calcasieu Human Services Authority for partnering with us for this important discussion. We hope that y'all have a great rest of your Friday and weekend, and happy holidays. Y'all take care.
Bye.
Bye.